Okay, thank you very much for this final session for this room this day. It was a busy day for all of us, and I'm happy to see the room still plenty of people. So it means that also just the title of this session will raise the interest from the audience. So my name is Marco Barbanti from Italy, and I will chair this session. I will be the pleasure to co-chair this session with my spokesperson, Chiara De Biasi from France. And also we had a great panel with Michael Droner, Julian Marshall-Bauer, and Mikko Savontas will enrich this session with a lot of discussion. But of course, the other person here is yourself. So please try to be interactive in this session. This session, it was designed to bring you into the cath lab, and I think the best way to do it is just to propose a few cases, and these cases will be not just regular cases. So the intention of this session is just to present not just TAVI cases, but to present a very complex clinical scenario. And then in this particular session, we'll see how one particular platform might perform in how it will perform in this very complex clinical scenario. I say that this is it's meant to be also interactive session, so you have some microphones there on the floor. You have an app, so I invite you to shut down your social media and then just connect with our app. So you have the chance to engage the panel, and Chiara will handle all the discussion from you, and we'll bring up to the podium any comments you wanna bring up to this session. So basically, we're gonna have three cases with three clinical scenario. The first one will be the combination of a coronary artery disease and severe aortic stenosis. Then we're gonna have a very tricky and angulated aorta. And we're going to have the last case with a Redo-TAVI procedure that we're going to see how to approach this very hot topic and clinical scenario. But I don't want to waste any more time, so I just want to invite the first presenter, which will be Mikko, to present this case. Mikko, please.
Okay, thank you, Marco, and welcome from my side also. So, okay, so this is my case. A patient with combined severe aortic stenosis and coronary artery disease, and I come from Turku University Hospital in Finland. These are my disclosures, and this is the case. So, this concerns a lady, 78 years of age. She has type 2 diabetes, asthma, fibromyalgia, and lives at home independently in a good condition. And these are her medications, nothing unusual there, I believe. So she had been followed for moderate aortic stenosis, and the previous visit was 2 years ago. And on her latest visit, she reported progressive dyspnea, which was currently New York Heart Association class 3. And she also had angina, like a separate symptom, which was about CC2, a little bit less than the dyspnea. ECG showed sinus rhythm with the left bundle branch block that had been there previously. On echo, LV dimensions normal. EF had sunk now. It was about 35% when 2 years prior it had been more than 50. And despite the low EF, there was a aortic valve calcified with a high gradient of 70/41 millimeters mercury, and the aortic valve area was measured around 0.5 centimeters squared. No mitral regurg. There was diastolic dysfunction, which is quite obvious. Right ventricular function was normal, and there was a right tricuspid gradient about 30 millimeters mercury. So based on this, she was referred for a TAVI evaluation. And this is her CT done at the referring hospital. So you can see this bicuspid valve with a left-right raphe. I would say this is like a moderately calcified, not heavily calcified. And it's a small annulus valve. This annulus was perimeter 72 area 397 and a perimeter derived diameter 22.9. Sinus Valsalva was decent side on this projection, 32 millimeters. LVOT was a little bit bigger than the annulus, so no problems expected there. And then with the bicuspid, it's always wise to do some supraannular measurements. At 4 millimeters, ICD was 25, and then you have this Lyra plane measurement, maybe a little bit subjective, but that was 64 perimeter 236 area, and STJ was 26. Then angiography was done due to her angina at the referring hospital, and we can see that there is a stenosis on the circumflex, but nothing was done to that at the time.
Okay.
So we can proceed to the heart team discussion. So I'll go over this and then we can discuss. So yeah, sure. So okay, to summarize, 71-year-old patient with aortic stenosis, reduced EF, coronary artery stenosis in a one vessel, bicuspid, moderately calcified valve. So I think it's clear that this is a TAVI patient. Our surgeons did not argue. I mean, it's a bicuspid valve, but it doesn't look hostile, and the patient is 71 years of age. But then more the question is the sequence of interventions. What can you do? You can do just TAVI and then PCI later if symptoms persist. Maybe that's the standard approach, but on the other hand, this patient doesn't have only dyspnea, she has also angina. You could do PCI first, then afterwards TAVI. I mean, this is a quite easy PCI, but still it's a low EF, severe stenosis, so you might get into some hemodynamic trouble when you do the PCI if there is still aortic stenosis. You can do TAVI first, then PCI, but then depending on the valve, you might have coronary access issues after the TAVI valve. And relating to this, what is the choice of the transcatheter valve? This is a bicuspid valve. I mean, there are different opinions on this, but at least we often like to use a supraannular valve in these bicuspid situations. And for sure, this is a small annulus also, so which also, if you think about the recent SMART trial, it's probably not wise to use a intraannular valve. And then, if you have a tall frame valve, then you have to think about what is the coronary access if you want to deal with the coronary artery stenosis. So we can pause here now and maybe discuss a bit.
Yeah. Okay. So thank you very much, Mikko. Michael, I want to start from you. This is a particular case. It's a young patient. We can consider quite fit. Is a moderate the LV dysfunction, but still no other particular comorbidity. What would be your approach a patient like that?
Yeah, first of all, I mean, this is a very good case. Thank you for presenting. So obviously this patient didn't have any aortopathy, so no dilatation of the ascending aorta. This is always a red flag to me. This is the time point where I talk to the surgeon and say, listen, maybe this is a good candidate for surgery if this patient is under good conditions also, no comorbidities.
Sure, yeah.
In this particular case, I think we are fine personally to proceed with TAVI. Also, we know that, Evolut performs quite well in bicuspid anatomy for small annuli especially. The big question here is, should we treat the coronary lesion? If so, should we treat it before or afterwards or concomitant? Our common rule is that we should treat the aortic stenosis first in a safe way, for many reasons also to reduce bleeding, complications, etc. if you have the patient under DAPT, and then see if he has symptoms or not, and proceed in that case.
So you raise a very important point. I think one of the option, one of the consideration here we have to do, because we have two combined pathologies, severe coronary artery disease and severe AS. I think the first step is to assess which one is predominant.
Yeah.
I think in this case, I would say probably the severe AS is the predominant disease, is a single vessel, is a tight lesion. It involves the LAD, but still, I think the valvulopathy is much greater than severe AS. And I think you say, well, Julia, would you say, well, probably I would leave this coronary alone, even though this patient has some kind of angina, and then treat just in case the patient keep on having symptoms, or what do you do with this?
I agree that this should be a TAVI case as we have the TCW data. And this is, although this is a diabetic patient, so the surgical discussion there's a point in it, but still we have TCW, we know that she will do better with TAVI, most likely. Regarding PCI, my approach would be to do the PCI with backup TAVI and have the TAVI already in the background and decide then how much contrast did we use, how is the patient doing, is she tolerating well, and then most probably we will implant TAVI in the same session. That's what we do, and I think this is a very safe approach.
Okay, so
it's probably not possible in every center, but in our center it's possible, and I think it's very appropriate and comfortable for the patient. It's all done in one.
And Chiara, how important is to have a prosthesis that can, in this particular patient, may guarantee a free and easy coronary access? Not just because probably we have to think that we treat this patient, but this patient may end up in any other centers in the territory, in even other regions and so on. So probably with no experience in TAVI field, so they have no idea how the valves look like. So how important in this particular patient, young, should be to have an easy coronary access?
So I will answer to your question, and then I'd like to share with all the panel the question that we just received. So indeed, there is no comments about the symptoms related to the aortic stenosis in this patient, right? So everybody said we go for TAVI first, and I totally agree because we treat the patient for the symptoms he has. But this is the patient where even if the stenosis was severe or intermediate, we need to guarantee the re-access to the coronary. Even if we are not treating this coronary, never, we need to guarantee that because we have to consider in the risk profile of the patient. So the importance to have a prosthesis that we put inside for a later on coronary angiography for whatever reason, STEMI, angina, stable or not, it's extremely important because we are putting the first device inside and we have to guarantee the optimal longevity for both the valve and the coronary. So the colleague just asked, would you make the same decision if this patient had a proximal LAD stenosis severe? So on my point of view, according to the symptoms of the patient, consider even that probably the first stenosis to consider is the aortic one. But I will share with you and with the panel what is.
Michael, what do you think about that? About this comment by our friend in the floor?
So the question, what we should be treating first?
No,
sorry.
If the LAD had the tight stenosis.
If the LAD, sorry. Okay.
The proximal LAD had the tight stenosis. Would you go for TAVI first as well?
Yeah. Honestly speaking, yes, I would treat the TAVI first because I feel much more confident now. I mean, we can then talk about valve choice, if you should use a balloon expandable with nice access to the coronaries. But I think we've also learned with this evolution of the Evolut FX, FX Plus evolution, I think there's a huge step forward in getting easy access to coronaries. I no longer feel so concerned, even only if it's let's say a stable proximal LAD stenosis. If you have this, those vulnerable plaque appearance, 99% stenosis, we would probably put in a stent in the same procedure just for the sake. But these are very rare occasions.
Okay. Yeah. Julia, is there, as mentioned, Michael mentioned, is there any situation where you say, well, you have to fix the coronaries first and then the TAVI afterwards?
Left main stem, proximal LAD, I would do so. I mean, it's a decision for me whether I have to do something on the coronaries or whether I leave it. Okay. If I have to do something, I would do it in the same session if possible or beforehand so that it is just fixed if the patient tolerates. If the patient doesn't tolerate very poor function, left ventricular function, I would do the TAVI first.
Yeah, because here we have also the LV function, which is not brilliant. So I think this is another factor that can play a role in the decision of how and when to go for revascularization. So we're looking forward to see what you think.
So great suggestions by the panel, but we didn't do either one of your suggestions, right? third approach. I mean, for sure, of course, this, if there is no angina, we would not treat this. We would leave it alone. But thinking it's a tight stenosis patient has angina, we do believe that. I mean, you never know for sure, but we believe that she might have angina even after the TAVI procedure. So this is what we did. We decided to do a TAVI first, and then in the same session do a PCR, because it's an easy lesion, and with the prosthesis we chose, FX Plus, we think it's going to be easy thing to do them both without not excessive procedural risk or contrast and these issues. So transfemoral TAVI using Evolut 26 FX Plus. I think 26 is a reasonable valve size. This was a 70 millimeter perimeter, not very calcified bicuspid valve. So I think oversizing, undersizing doesn't play a role here. Safari XS wire pre-deal with a 20 millimeter true balloon, maybe a bit conservative, but with bicuspid you respect the rough, so we are not going to go with a bigger balloon than that. Right radial for secondary access, as is our standard, and 1 prostyle plus an 8 French angioseal for the femoral closure, also our standard approach. So this is the case. We start with the TAVI. I'm all running here. So of course here, if this plan is to work, we have to be sure that commissural alignment is okay. And with FX Plus, it's quite easy when you go to LAO3 and you follow the hat mark on the outer curve, and you can already see here that it's quite well with one dot on this cusp overlay projection pointing on the right side of the screen. And here we are at almost 90% valve opening. We like the position. The dots are about at annulus level, 3 millimeters. So I think this is a safe position to release the valve. We checked on the left side. I don't have the images, but that was also okay. And then, so then here is the valve after release. Position we like. There is some AR. Could be from the Safari, but we are quite low threshold for post-dilating, and also to my eye the valve looks a little bit underexpanded. So we took a 21 true balloon and did a post-dilatation here. This is after the post-dil, and this is after taking out the wire, showing a nice result. So then this was all uncomplicated, patient was stable, not much contrast used, so we felt it was okay to move ahead with our plan. And here, it's really easy now with the standard Judkins guide from the femoral to cannulate the left main, no issues there. Then we just wire the CX, this balloon, and then put a Orsiro stent to the stenosis. And here is the final result. And post-op care was uneventful. First post-op day echo, gradient 8/5, aortic valve area 1.9, no PVL. And there was no change on the ECG. The LVBB was still there, and she was discharged on post-operative day 2. And she had a clopidogrel for 3 months and then just aspirin. And on her follow-up visit at 3 months, she had no dyspnea, no angina. EF had started to come back a bit, 45%, gradient 11/5, valve area good, and no PVL. So all fine.
Okay. Thank you, Mikko.
Thanks.
I just want to ask Kelby if any from the audience had comments, and then...
Indeed, this discussion is a real hot topic because the chat is really alive all the time. So I would like to thank the colleague, Dr. Bansal, Dr. Oskan, and Brigopoulos. They are really concerned about the treatment of this patient with TAVI before PCI. I mean, they are asking, is it an option to consider in this patient CRTD and PCI and re-evaluate? And is there a risk if we have the PCI to pace this patient during the implantation of the valve? Is there any risk? And if you have any tips and tricks for the pacing in this kind of device implantation. And of course, they have a doubt about the DAPT, so the treatment that we need to do if we perform both TAVI and PCI.
Great points. I mean, regarding the CRT, we did believe, since the ejection fraction had sunk over time, we believe that the main reason for this was the aortic stenosis. So I think it would be over-treating to put a CRT now and rather put in the valve first, and as happened, the EF started to come back. So then I think this I mean, it may be, but I don't think that would be maybe the optimal strategy. And what's the other thing about the pacing with the coronary stenosis? That was the question?
The DAPT.
Oh, DAPT, yeah. Okay, yeah, of course, you take some bleeding risk, but she didn't have any high bleeding risk features. She was not on anticoagulation, so lab work was normal. I mean, she's 78, of course, that is some bleeding risk. And creatinine function was also normal. So I think of course, there is some bleeding risk, and the studies show that DAPT will increase the bleeding risk in these patients. But I think it was still a reasonable thing to do, given her angina. I'm just stressing the point that we wanted to treat her symptoms.
Okay, thank you. I think we thank you because there are a lot of comments, so we have to move on next case. But of course, Mikko will be out of the room responding to your answer after the session. And please, I invite Michael Joner to present our second challenging case.
All right, thank you very much. So let's maybe, first of all, start with the conflict of interest. That is important. We all have conflicts and they need to be disclosed. That's the good news. I think it's a good news for all of us because we have the second valve approved for the performance and treatment of Redo-TAVI. And I think this is urgently needed as we see more and more of these patients. And we know the benefits of supraannular designs. So I want to present you a case of a patient, male patient, 79-year-old. He received a SAPIEN 3 by that time for severe degenerative aortic stenosis in 2018. He has coronary artery disease and had received prior stents to the LAD circumflex and RCA in 2018 and 19. As comorbidities, he has hypertension and dyslipidemia, and he has atrial fibrillation treated with an oral anticoagulant. He is on drug treatment, rosuvastatin, 20 milligrams, candesartan, apixaban, bisoprolol, and ezetimibe, and amlodipine. I'm showing you his blood work, which is unremarkable, normal kidney function, and his NT-proBNP also within a slightly elevated range. Now, this is the patient, how it presented. He really presented with exertional shortness of breath, and you can see it's maybe a little bit hard to see that he has some level of pulmonary congestion here. And this is his aortic valve, the SAPIEN valve, which we looked at very carefully, and you can see that really elevated gradients were measured over this aortic valve with a max gradient of 52 millimeters of mercury and a mean gradient of 32. Really, again, this patient is on NYHA class 3 and was diagnosed with cardiac decompensation and pulmonary congestion. So the question really comes up, how would you treat this patient? And maybe we stop here and then continue after a short discussion.
So thank you, Michael. So I think, as you said, this is one of those cases we're gonna, now it's quite a rare phenomenon, but probably we're gonna see much more frequently in the future. And but probably the first thing is it enough? So can we treat this patient? So I just want, I don't know if is it possible to have some light on the, just to challenge the friends that are here. Would say that, okay, we can treat this patient with a Redo-TAVI procedure. Please raise your hand. Raise your hand. Okay, we have, so we can, there are some people say, well, we can treat it. Who would say we cannot treat it? Nobody? Who would say the information that Michael provided us are not enough to say if, okay, we have some people also. Michael,
yeah,
is it enough? What do we have?
Probably not, I would agree. So usually we do TE also in all patients with degenerated bioprosthesis, including TAVI prosthesis. In this particular patient, we decided to go for a CT assessment first, and I will go through this together with you to make a reasonable assessment whether Redo-TAVI is feasible. And this is his native CT scan before the SAPIEN was implanted by that time. And you can certainly see it's a tri-leaflet structure. It has moderate calcification. And you can see that this is the valve that had been implanted by that time. It's a 26 millimeter SAPIEN 3. So it's not an Ultra, it was a SAPIEN 3 here. But this is taken from the Redo-TAVI app. So I thought it's good if we go through these step-by-step procedures together with you. And it is important to know some of the features of these valves because this will determine on how safely you can treat. So you don't need to remember all of that. The height, the skirt height, all that kind of stuff is really captured in the Redo-TAVI app, or you can also look it up in the internet when you look at the manufacturing, IFUs, etc. What is suggested to be done is that you perform 3 measurements throughout the inflow, outflow, and the waist region of this SAPIEN valve. And you can see those measurements were done, and then the app automatically calculates an average area and perimeter-derived diameter out of these 3 measurements. And you can see this was coming up to 445 square millimeters, averaging or showing a perimeter of 75.6 millimeters. So this all in all then would go with a 29 millimeter Evolut if we decided to do so, but I'll show you some more information. Also, importantly, you have to look for commissural alignment of the first valve. And as we all know, that SAPIEN 3 doesn't have the capability of achieving commissural alignment. With newer devices, maybe that may be possible in the future, but here it isn't. So we can see at least moderate commissural misalignment because the stent, you can see the strut is the commissural post is very close to the takeoff of the coronary artery. So that needs to be considered. And then finally, of course, we need to simulate what we eventually want to do, and then we can perform measurements. We have to take it step by step again, but we have to also stay simple. So first of all, what you should consider, where is your commissural tab? Because this will determine the neoskirt plane. And you also have to look at the coronary risk plane. And if the neoskirt plane is above the coronary plane, risk plane, then it automatically becomes an intermediate risk procedure. That means you need to do some additional measurements in order to judge whether you are safe or unsafe for this procedure with regards to the risk of coronary obstruction. And then this is again a slide showing you basically all these measurements. In essence, it's simple. You have to measure the distance to the takeoff of the coronary artery. You do this on a cross-sectional level. And then you can also measure different distances to the aorta, VTA, valve to aorta distances, and you should pick the smallest of those. So again, if the neoskirt plane is above, then you have to measure the VTA, and that's what we've done in this particular case. You don't necessarily need to measure the VTSTJ because this was actually fine in this particular case. So you take the smallest of all the 3 measurements and you type it in, and you see for the RCA this was 4.9 millimeters, and for the LCA was 5.4 millimeters. So this then tells you again, this is relatively low risk of coronary obstruction. Now, really speaking, it's, we don't know so much about it because we don't, either you then decide to protect the coronary arteries or you don't protect, but we never know the outcome if we didn't have done so. So this is kind of difficult. And in this particular case, we weren't quite unified amongst our heart surgeons and the interventional cardiologists whether to protect or not protect the coronary arteries. Just for the sake of discussion, I'll show you the coronary angiogram that we had done. This looks kind of okay, but I leave it up to you to further discuss. Sorry, that is already advanced. I'll come back here, and maybe let's stop here to discuss whether we should protect or not protect.
Okay, so thank you, Michael, because actually this is, I think a snapshot of how complex can be an assessment of Redo-TAVI procedure. So this is one of the messages of this case. So I think the feasibility of Redo-TAVI is really dependent on this kind of a very deep assessment. So this is very important. So first of all, to assess the feasibility. Julia, according to this very tricky case, what would you have done? So what type of valve, what type of approach would you have done? Protection with the coronaries, and what type of valve to use in this case?
Yeah, I have a further question in advance, because this is a short-term degeneration of a sapien valve. How do you test for valve thrombosis? Because this could still be an issue in these patients. I've seen patients we put on oral anticoagulation and it resolves.
Yeah, that's why I mentioned, which I wasn't able to show early on, is what we always do in these patients is run a TE in addition to the 4D CT assessment. So we really look for hyperattenuate leaflet thickening. We look for reduced leaflet motion, signs, indirect signs of valve thrombosis, leaflet thrombosis in these patients. And only if we are clear and in consensus that this is no valve thrombosis, then we proceed with Redo-TAVI.
And for the coronaries, I would absolutely put in a wire.
Yeah.
For the protection wire for the procedure in this situation.
Would you protect both coronaries or only one?
I think I would certainly protect the left. The right, I don't know how, was it above the frame, the takeoff of the right?
It was below. The coronary plane was below the neoskirt plane for both, slightly below, not a lot below, but
below
I can show again.
The sapien frame.
Oh, sorry. There we go.
So the left is certainly below, and the right is also
it's
below.
about the same height. I mean,
there was 4 millimeters at least was the VTC.
Was it
that was here, 4.9 the VTA. This was just measured because exactly for the reason the coronary plane is below the neoskirt plane, and then you have to measure these VTA distances, basically.
Okay, this is very important. It makes really an idea how complex can be, and I think to summarize these points, and I think it's important for our audience, you have to make a global assessment of these cases by integrating the risk of obstruction, of course, because the problem is the obstruction coronary, the sinus-valsalva sequestration, and I think you have to combine the risk, the folding up of the index valve, but also another important step is to measure the sinotubular junction. As long as the sinotubular junction is quite wide, you're still okay, even though you have quite borderline annulus. So sinotubular junction, which was quite a neglected measurement a few years ago, now in terms of Redo-TAVI procedure, and this has to be thinking also during the index TAVI procedure is something has to be measured. Sure. Mikko?
Yeah, I mean, I would not protect coronaries. I would trust that this is at least 5 millimeters. I would believe in that, and maybe that's introducing unnecessary complexity to procedures. I would trust it that if it's more than 4, I never had a case that coronaries would be obstructed. Also, the SGJ, I mean, I believe the sapien is below the SGJ, so it doesn't play such a big role in this case. But of course, that's still about 2 millimeters, so that should be safe also. So
and okay, Julia. So just move. What type of valve would you redo? A small stent valve, or would you go with a supraannual tall frame valve?
Well, the sinotubular junction looks quite narrow, but I think that the preferred approach would be a tall and a short.
Because
so we would first check for that, and only if we are very uncertain about the coronaries that we cannot protect properly, then we would go for a short frame. I mean, this is a 26, so we can put in another 26 sapien without problem.
So you pay attention also to the valve performances and the mismatch for this patient, which is an important point.
But it once failed, the sapien, so one is more prone to try something else now.
Yeah, but I think it's important to consider this patient that this valve degenerated with stenosis. So as long as if you put the new valve in, you're not able. We put the 26. So just in case we have to put the new valve in, it's not linear that you are implanting a new 26 because you have a lot of material
Correct,
between
yeah.
frames. So probably you need to put a 23,
Yeah.
and probably you pay this with some mismatches. So I think also in my view, as the possibility to implant a supraannual valve,
Yeah.
it might have a sense. You wanna?
Exactly right. I mean, that was the thinking in this particular case. Is what you said is exactly right. You may end up with underexpanded 26 millimeter sapien valve if you put in a new one. Then you can, of course, try to compensate for this with high inflation pressures, but oftentimes it doesn't really work because the material is very strong. So the concern was of PPM, as you said. You have a patient prosthesis mismatch in case you put in another 26 or 23 even. That's why we decided to go for a
Okay,
Evolut.
our patient is waiting for treatment. So Michael,
sure.
tell
So
us.
that is really relatively quick. I don't have a lot of slides to show here, but what I want to point out is that the decision making in this particular case was really to protect or not protect the coronary arteries. And it was decided, another factor that we haven't heard is the height of the valve that you implanted, and that we got used to implanting sapien in degenerated Evolut or accurate valves, a bit at least. We've done some cases, most high volume centers have some experience, but there's not so much experience of doing exactly the opposite, what we've done here, a tall valve into a short frame valve. And usually, I want to point out that when you look into this Redo app, the recommended height is inflow to inflow for the Evolut in sapien. And you can see that this valve dived a little deeper. It was done partly on purpose to protect the coronary arteries because your risk plane then goes lower. And we also considered this was a patient that had received prior stents in the circumflex and LAD, and we wanted to be able to access the coronary arteries in the future. This is why we intentionally implanted this valve a little lower, and we, of course, can discuss about that potential limitations of that, because what the manufacturer says, it may be that this has an impact on valve functioning, on the leaflet function. The leaflets are sutured in a level where the sapien posts are located, so this may have an impact, but we saw, at least on the echo that I'm showing you, excellent hemodynamic outcome with a mean gradient of 6 millimeters of mercury. So this was some sort of confirmative to us that this was a good result and may have the advantage of better coronary access in the future. That's it. Thanks.
Thank you, Michael. I think it was a really great example how the Redo-TAVI procedure is now one of the hottest topic in our field. I think is important, and so far we have been quite, the perception that probably the only way to treat it is just to put a small stent in. But I think this is a nice demonstration how also a supraannual device might play an important role in treating this important pathology, because we're going to see like a wide range of pathologies of degenerated valves. So I think it's important for us to have a very important different tools to treat it.
Yeah, and maybe one additional message from my end is that we as a community, I think we need to share these cases and the knowledge, because we are at a phase of learning where we know nothing about it. We don't know the hemodynamic consequences if we implant high versus low. None of that is known. So we all need to work together as a community to get a better understanding of what we're doing.
In terms of, tomorrow there will be also a session regarding this. So I invite you to attend these sessions on Redo-TAVI, which will be very important. So I think it's time to move to our last case, and I invite Julia to present another complex clinical and anatomical scenario. Julia.
Yeah, thank you. Yeah, thank you for the invitation. My task is to show a patient with a complex large aortic valve anatomy. My conflicts. So Mr. BK, 88 years old gentleman, was admitted to our hospital due to cardiac decompensation. And during his workup, it turned out that his kidney function was very poor. He was a pacemaker carrier since 5 years, still an active smoker with chronic obstructive pulmonary disease, and he was also hypertensive and had suffered a dyslipidemia, but otherwise he was in very good shape and self-dependent. This is his echo at baseline, poor quality, what we can see is that his left ventricle is normally sized and the left ventricular systolic function is preserved. The aortic valve is thickened. The maximum velocity was only 3.0 meters per second, and the area was calculated at 0.8 centimeters square. The atria were enlarged, but otherwise the echo was unremarkable. So we were left uncertain with this diagnosis of a paradoxical low flow, low gradient aortic stenosis, and we didn't know whether his cardiac decompensation was due to the aortic stenosis probably, or the poor kidney function, or any combined problem. And the first thing that we do when we see patients like that with uncertain aortic stenosis severity is we do a CT scan. And we saw that this was a tricuspid aortic valve, but quite some calcification. The total Agatston score was over 3,000, and so he was quite above the cutoffs for the indication of severe aortic stenosis for men, which are, according to the current guidelines, around 2,000 to 2,200 Hounsfield units. So the diagnosis of severe aortic stenosis was confirmed on CT. As this gentleman was 88 years old, we did not discuss with the surgeons. We went right further into TAVI evaluation, transfemoral TAVI evaluation, which is the preferred route, and we can see that the femoral arteries have a favorable anatomy, although there's some kinking, but no significant calcification. Measurements of the LVOT revealed quite a large area, an average diameter of 27 millimeters, and no calcification at the level of the LVOT. So, in principle, this patient would be suited with an Evolut FX 34 millimeters. I don't know whether you would like to discuss now if we
okay, so
could also choose another type of prosthesis.
Okay, so this is another. I think the clinical profile of this patient is a very high risk patient. It's 88. It looks like quite fragile with 20. Of GFR. There's a severe AS. I'm not sure. I saw the angle of the aorta. I don't know if you have a.
The angle of the aorta is coming next.
Exactly. So that's another point that has to be discussed when you decide what type of valve you want to implant. Michael, do you want to do some comments according to the clinical, which is, from a clinical standpoint, it is a very high-risk patient.
Yeah.
But from an anatomical standpoint, what type of consideration when you choose the type of valve you want to use in a patient with I would say, quite horizontal aorta?
Yeah, that's an important point, and I think this is the important point that lets many operators decide to switch maybe from a supraannular self-expanding to a balloon expandable valve, because I mean, we can all agree it's much easier to implant a balloon expandable valve in such an anatomy. It's not easier maybe, but it's safer because you can easier predict where it's landing. Now, I think once you get some experience with this new, again, we come to the evolution of Evolut series of valves. When you ask me, would you have done this with an Evolut Pro or Pro Plus, I would have felt, a little bit uncomfortable and rather, prefer to choose a balloon expandable valve. But now with the new generations, the implantation is much more stable. It stays where it's supposed to stay, and I feel more, happy to implant a self-expanding valve also. But at the end of the day, would I have chosen a self-expanding valve? I'm not sure, to be quite honest.
Yeah, this is not a beginner's case, I admit, but we always assess the ascending aortic size and how long it is stretched the stenosis, and in this case it was favorable. So we knew that the aorta would not push the prosthesis too much down. But still, I agree, this is of course something that has to be acknowledged.
We have probably some comments from the audience.
Yeah, I would like to ask to Ginthaus, a colleague and friends, to keep the microphone just in face so that we can just understand better which comment would you like to do, because he is asking about the measurement of the LVOT, and I would invite you to take the microphone. It will be nicer for you.
Yeah, no problem. I hope it works. Yeah, hello. Interesting case. Of course, we all know that the large anatomy is always the most tricky to handle, especially with self-expanding devices. These big valves are always more rough and less stable, especially when you talk Evolut. It's very tapered towards the waist and very wide towards the bottom, the 34 version of it. So what we usually do when we try to decide which of the bigger devices should we use, we check also upper LVOT. If it's widening, which I have a suspicion of looking at this very image that you're showing, then you know that you need to implant it extremely high in order for it not to dive. Extremely high, which is like 0, at least. If it's even 1 or 2 millimeters below, according to IFU, there's a risk it may fall down. You have rather wide aorta, which will be difficult to stop that valve from diving. If it dives, it may still give a reasonably good result. You may get away with it, like sometimes you do. But you don't necessarily want that to happen. So that's what I mean.
So I think that maybe one comment that we can do is that when we look at this anatomy, we are looking even to treat this anatomy with a device that can stay stable. So probably what we look in our device, whatever it is that we are going to choose, is a flexibility in order to challenge the alignment in this kind of anatomy and the stability. And if we can align even better, but of course here you are scared about the diving of the valve into the LVOT. But if we consider this measurement into the analysis of the annulus as well, and we have a platform that we can control better in terms of symmetric implantation, probably even a long stent could be feasible in this anatomy.
Indeed, even Evolut can be feasible, don't get me wrong. It's just that, you have your concerns, and if in case the patient is suitable for several devices, you would take that into consideration.
I absolutely agree with you. These are very valid points that you raised. And of course, if you are not very familiar with the platform, you should probably abstain from cases like this where the prosthesis can dive. I will show that in a minute.
I think the point is that sometimes we have to consider that most of our anatomies, they may be suitable for different platforms. And I think the reason why we are here and discussing this important case that horizontal aorta so far has been considered one of the niche, one of the best niche for balloon expandable devices. And I think this is true, absolutely. The perception is this, but I think it's important. The aim of a session like that is to demonstrate that probably we have to just open up our mind that we have new technology. I would say that with a very early generation core valve, or probably even Evolut valve, this kind of consideration is particularly true. Today we have new platforms, so new Evolut that is evolving, and it really provides you much more easy of use, and also in this tricky scenario. But we'll see how Julia handle it. Mikko, do you want to make any consideration regarding this case?
Yeah, sure. I mean, this certainly is a complex case, but we don't shy away from horizontal aortas when using Evolut. But also the point Ginthaus was making that this is on the annulus on the smaller side for the 34. So in this case, there is, I think, a bigger chance of it diving down, and maybe it's easier when the annulus is around 90 or something, but certainly doable with an Evolut 34. Let's see.
So Julia, let's see.
The point is also that we sometimes see that the aorta is much more horizontal when we in the middle of the case. So from the measurements of the CT, it did not look so horizontal, but then we see all of a sudden when everything is in, the valve is crimped and open, that this is a horizontal case. So sometimes you choose or you don't know in advance. So the next step, of course, is the evaluation of the coronaries, although this gentleman is 88 years old, and we are very conservative in my center concerning the coronary treatment of coronary artery disease, particularly in elderly patients. So regarding the height, this is favorable, and as we can see also from this stretched analysis, that the left ventricular outflow tract is tubular or more or less tubular, which is good. And then the discussion, of course, comes up whether we should do invasive coronary angio. And particularly in a case with a very elderly gentleman with severe chronic kidney disease. And what we do now in our center is the multiplanar reconstruction of the coronaries from the routine mandatory CT scan, TAVI CT, and in many cases we can rule out significant coronary artery disease of the proximal segments. In almost all cases, we can rule out or in. And in this gentleman, we saw that the coronaries were free of stenosis, so we abstained from invasive coronary angio and went straight forward into the case. If possible, or almost always, we predilate. We do a good predilatation, particularly in tricky cases, because we have noticed that then the implantation is easier. We used the implanted pacemaker for pacing. And this is the first shot after the first attempt to implant. And as you can see, we landed quite low, too low. So we recaptured the device. What I can show here, again, sorry, can I play this again? What I can show here from this cusp overlap view that we did commissural alignment and it worked. You see one dot on here and two dots on the other side. So in the second attempt, you see the valve popping down. Do you see it? During the contrast injection, you see the valve sliding down into the left ventricular outflow tract. So we did a third attempt, and we kept the valve very high. So attempted a very, very high implant and also paced more rapidly. And we were very satisfied with this position and put on more pacing than for the implantation. And this was quite a fast implantation, and as you can see, it was more in a forward movement even. But it went very well. And this is the final shot, but he implanted at 0 height. And this is the echo on the first post-interventional day. The left ventricular function looks fine, and we have a peak velocity of 2 meters per second, no paravalvular leak. So this is an excellent result, and the patient was discharged on the same day.
Okay, thank you, Julia. I think the main message we back home, I don't know, I just want to have the feedback and the feeling from the panel. I think when you have these tricky cases, large annulus, so you're using a 34 platform, you have horizontal aorta. I think my personal opinion that pacing it's really key in assessing and to making everything more stable. And I think I agree that in this case you have to stay quite high. I think in this case, when you have a large, large sinusoidal valsalva, larger sinotumoral junction, stay high, it's really not a problem. You didn't do high implantation because of pacemaker, because the conduction disturbances, because the patient already had a pacemaker. But from a technical standpoint, Michael, I want to listen to your opinion, but I think a stay high and very small, very slow release and much control is key.
Absolutely. I think Julia has nicely shown it was a perfect job. This is not so easy. You have to do some FX plus before you do this case. You said the right thing initially because you need to figure out exactly the right height. And you did it in your third attempt with fast pacing or faster pacing. I think everything done in the right way. Yeah.
Mikko, do you have any tips for such trick anatomies?
Yeah, may I could ask you, like, did you on your last attempt, did you give tension on the wire? Did you have some wire? Because that's a good trick to give.
I forgot to say. So we put more pressure on the wire, and the first operator put more pressure on the wire and bounced it out. It needs some. Practice, but it is possible.
Exactly the point. This excellent result is not play of chance. It comes for accurate planning of a few technical adjustments, which means implantation 8, play with a wire pacing, and then a very small, very slow deployment.
This is exactly the question of a colleague in the room. So to bring the valve up and avoid diving into the left ventricle, as first operator, give a backward pull on the delivery system or push the wire farther in the LV. I mean, it's a question of support, I think, as you were saying. And of course, the pacing. We started to implant all this platform under pacing, and this really changed the control during the deployment.
Yeah, we even do rapid pacing sometimes. So with 180, if it is very unstable.
Yeah, and maybe one tip, you could have used a Lunderquist wire. Usually we don't do it for this technology, but in this very horizontal aorta and the tendency of the 34 to dive into the ventricle, it gives you more stability sometimes.
Okay, thank you very much, Julia. Okay, now it's we had 3 excellent cases. We just presented this new technology of FX Plus. So I just want to conclude by summarizing which are the real features of these new devices. This is my conflict of interest. The evolution of Evolut platforms starts from almost 2 decades now. We have the core valve, the first implant in 2007, and I think one of the most important part of the story that when we present long-term data, I think we have a unique data on this platform, which is represented from the Notion trial, which enrolled in a very early stage of TAVI, quite low risk and young patients. So we are really able to assess the longevity of our prosthesis. And what we showed that actually the core valve was able up to 10 years to have a very low incidence of severe structural valve dysfunction as compared also with surgery. And when we see here also mean gradient more than 30, we have at only 1.5 and versus 10% of surgery, which was significant. So it's important to start from this concept that when we assess platforms and we assess in a new technology platforms, everything starts from something that we already have well demonstrated that it has longevity. Then the evolution, it took almost 7 years to have a new generation valve, which is the first Evolut R, and basically addressed all the major issues of that particular part of the story. So this was back 2014. The major issue of the core valve that was a self-expanding device, but at the very beginning it was not able to recapture it. So the main feature of the Evolut was be able to recapture this valve. Then 2017, the problem was the leak. So how to solve the problem of the leak? So the Evolut Pro, it came for this aim, and by adding the pericardial external wrap to mitigate the phenomenon of the PVL. Once again, 2019, the introduction of Evolut Pro Plus, reduction of deliveries of the delivery profile, and also the widening of the annulus that can be implanted. More recently, with the Evolut FX 2022, we had the possibility to have as Julia just showed, a much more controlled implant. So it means that we basically assessed all the major issues during the time, but the main problem was we still have this very long frame with the closed cells. And the problem which came out in the last few years was how is it possible to reaccess to these coronaries. So, well, the new FX Plus basically come with this aim, create larger cells in order to facilitate the reaccess to the coronaries, and we nicely see from the data presented from the case presented by Miko. But I think one of the major points when you develop valves is yes, you can make some improvements to the device, but from engineer standpoint, you really need to maintain what you have in your background, which means the longevity. Because if you basically change completely the frame, it starts from really beginning, and then the data you observe a long term, it's not valid anymore. So it's mean that when you assess the last with the previous generation, you basically have no impact in outflow, inflow region, and most on no change to valve assembly or attachment of the leaflets. You basically created with the new Evolut FX Plus, you created the larger cells, which is different, and then is different across the all the 4 dimensions and the 4 sizes of the valve. This is also very well visible on fluoro, which is important because also we present a lot of images of the valves, but as a physician, so we see the valves with this appearance. So it's very important to have a fluoroscopic feedback of these open cells, and this is the marker here. It's quite visible on fluoro. But the question may be, okay, but open these cells. Do we have any compromise on the function of the valve, of the integrity of the frame? Well, the Medtronic did a lot of assessment on this valve, because remember, the core valve platforms now has more or less a 20 years, 18 years story. So really, it's very key, it's important not to lose this unique feature of the valve. Well, the test, it was done in lab, demonstrated that there is no the difference observed with the previous generation device. So this open cells has no impact in functional of the leaflets. But more importantly, that probably was the most important aspect that my right side conserves is the integrity of the frame. Also in this case, bench tests demonstrated that there are no impact of these open cells on the functional integrity. So we basically can say, and of course I'm sure that data will need to demonstrate, but we are reasonably confident that the device and the function of the valve for the new platforms by opening the cells has no impact on long-term outcome. So to conclude, the main features of Evolut FX Plus valve is to create a new design, basically to maintain the good features of good valve performances and good longevity, but facilitate coronary reaccess by opening the cells. And of course, the beauty is that basically we just with this valve we just open the cells, but basically maintains of the good features we have. So thank you very much.
So probably, Marco, we can just wrap up this session and understand what we learned together. And of course, there is not a dogma in using one device, 10 devices, and probably more devices can fit different anatomies. But what is important is that when we challenge in our TAVI, when we face bicuspid, small annuli, when we face the need of get again into the coronary, so to preserve them, when we have challenge like horizontal anatomy, very large, we have the possibility to choose different devices, but even counting on the different designs in terms of hemodynamics, so good hemodynamics for the future, no PVL, re-access to the coronary. And so not only the short stent, but even the long stent could be the platform that we could choose in these challenges. Anything to add? Thank you very much to everybody to participate and enjoy the rest of the PCR.